I'm Dr. Gazinfer, moderating the session of today. So this is a fellow session 3. So first of all, I would like to invite the panelists and chairpersons of the session, Dr. Nasirur Rahman, Dr. Naeem Malik, Dr. Mansoor Ahmed, Dr. Amer Rauf, Dr. Bashir Solangi, Dr. Najibullah Tareen, Dr. Tahir Naveed, Dr. Ahsan Iqbal. Thank you, sir, and thank you, madam. So basically, this is the fellows corner, so we have to start the cases. So first case is by Dr. Amer Rauf from AFIC. He will not present a case about the complex pacing and the defibrillation lead expression challenges case. Dr. Amer Rauf.
Bismillahir Rahmanir Rahim. Thank you very much for giving me this opportunity to present this case here today. So the topic of my case is complex pacing defibrillator lead extraction and its associated challenges. First of all, the case presentation. So my patient is a 54-year-old gentleman, known patient of diabetes mellitus, who had an episode of acute anterior wall MI in 2005. Later found to have double vessel coronary artery disease and treated with PCI to LAD and RCM. In 2008, he had sudden cardiac arrest. Thankfully, he was revived after 25 minutes of CPR, and ECG at the time revealed monomorphic ventricular tachycardia originating from anterolateral wall of left ventricle. Now, for secondary prophylaxis of sudden cardiac death, single-chamber ICD was implanted in 2008. The first ICG generator change was done in 2014, and at that time, right ventricular pacing and defibrillator lead was found to be damaged. And in the absence of dedicated lead extraction program at the time, it was decided to implant another lead, which means the initial faulty lead was left in place. His second generator replacement was performed in 2022. Unfortunately, 3 months afterwards, he developed fever, blood cultures were positive, and there were also vegetations attached to right ventricular lead. So in this situation, it was imperative that in addition to admission of appropriate antibiotics, whole pacing defibrillator system should be extracted. At this stage, the patient was referred to our center for lead extraction. Now, before I proceed further, I want to highlight why lead extraction is such a big problem, because we understand implantation, if you spend 2 months, 3 months doing it, it's not such a big job, especially just the implantation part. But the problem with extraction is this, that with the passage of time, depending upon the time that the lead stays in the body, there are formation of tough adhesions between the lead and the endocardial surface of the heart and the vessels. Now, with the passage of time, these adhesions can also calcify, and in this situation, you can understand that it is simply not possible to pull the lead out of the body. So in order to overcome this problem, we have at our disposal some specialized tools. For example, this is Amer laser lead extraction tool, in which, first of all, a lead locking device is inserted, which holds the lead in place and prevents the lead from disintegrating. And then over this lead, a laser sheath, which is called glide light, it comes in different sizes. It is placed over it, and then it gradually clears the adhesions and separates the lead from rest of the body. So that is how it is separated. The second one, now this is a mechanical extraction tool. This is called tight rail. It has these circular running blades at its distal end. It is hand operated. And unlike the laser, this one physically cuts those adhesions, and that is how it advances. The major difference between two being, though they are same in the cost, that this tool is more preferable if there is heavy calcification. So next, let's review some complications. The biggest or the dreaded complication, of course, is SVC tear, which most commonly occurs at the junction of SVC and right atrium. There are risk of tricuspid valve avulsion if the lead has adhesions at that level. And of course, there could be myocardial perforation. Now, in all of these situations, there is requirement of emergency surgery. That's why, among other things, we require a bridge balloon. It is a non-compliant big balloon which is used to temporarily seal the lesion to buy some time in which the surgeon can open the chest and repair the lesion. And of course, the procedure is preferably performed in a hybrid lab because there is no time to shift the patient to a dedicated OT in this situation. One of the problems in Pakistan, of course, is that its gadgetry is quite expensive. Now, details of the procedure. So, in the beginning, you can see these two leads. Among these leads, we can see a TOE probe. One is the new lead, which was implanted in 2014, and the other one is the faulty lead implanted at first. So at the start of the procedure, we used glide light. This is the laser sheath, which I talked about. Initially, we were successful, and we were able to separate the lead till the area roughly at the junction of SVC and right atrium. But we found it difficult to advance any further, and this was the stage when we decided to switch laser sheath with a mechanical hand tool, which is tight rail. And indeed, with the help of tight rail, slowly but gradually, we were able to navigate and separate this lead. So this way, it makes small progress. You have to be patient, but gradually, it is, if you do it gradually, eventually the procedure becomes successful. So similarly, we did the same thing with the second lead, which was then also extracted in this way. Afterwards, of course, usually what we do in this patient is that once a device is removed, we reassess the indication for that device. Because this device was not implanted at our center, if the initial indication was valid, after waiting roughly for 1 to 2 weeks, when the lesion heals, we reimplant the device, usually on the contralateral side. In the end, an overview of lead extraction program and FIC. So FIC is the only cardiac institute in the country which is offering pacing defibrillator lead extraction via XMR laser. The program was started in 2018, and so far we've extracted around 80 leads successfully. The biggest impediment is high cost of the procedure. But we hope that with increasing volume and awareness, the cost of each procedure is expected to come down. Thank you very much. Now, if there are any questions.
Thank you very much, Dr. Amer. I want any comments from the panelists? Dr. Mansoor Sahab, do you have any comment for this case?
In fact, in my training days, we had to do everything, invasive, non-invasive, EP, and everything we used to do. And we are living in very good times, frankly. Those days, there were 20% rate of lead displacement after pacemaker within a month. Lead fracture was not uncommon. Infection का ये हाल था कि हमने लेस्टर में हमारे जो EP वाले थे, he designed a कि जी pacemaker के entrance इधर से है तो एक tunnel बनाते थे इधर, hoping कि infection अगर इधर शुरू हो तो यहाँ पहुँचने से पहले उसे पकड़ लें. So infection is such a serious issue. Once it is there, you literally have no option but to remove it. Now, lead extraction is a highly specialized affair. It is nobody's job that you just pull the lead out. You can't. Even after a month, don't even try. If it's displaced or loose, you can manipulate, otherwise not. So I'm so happy that somebody has got this facility available somewhere, or fortunately, it is not such a big problem. Or lead fracture is now extremely rare. मेरा ख्याल है in the last 20 years I've seen one possibly. उससे पहले it was not uncommon because of the material used. So infection is something very serious. The foreign body has to be removed. Without it, you can't do nothing. The interesting thing is, if you have vegetation at the tip of the lead, you take the lead out, but still the tissue is left, infected tissue. So, as you mentioned, there was some vegetation. What about antibiotics? Do they work, or do they take longer than usual, or does it never recover? Any idea?
Sir, this is an excellent observation. This specific aspect is studied in the pre-procedure
Yeah,
period.
I can't not see you. ये light आ रही है मेरे eyes पे. I can see the light, not your face. हाँ यार ये.
So as I was mentioning, this is something which is designed and discussed in the pre-procedure period. So if the size of the vegetation is bigger than the lumen of the sheath that we are using, in that stage, we try to administer antibiotics, wait for the period when either the vegetation size reduces, or if the patient requires an emergency extraction, then in that situation, surgical extraction is something which is preferred. But if the size of the vegetation is as such that it is smaller than the size of the sheath, because the sheath we were using is of two sizes, it is either 13 French or 16 French. So if the size of the vegetation is smaller than that, what we have seen is this, that we can successfully extract that lead even with vegetations. And second part of the question, antibiotics, yes, antibiotics would continue even afterwards. And antibiotics, they work and they function and they perform much better when the lead and the vegetation has been removed, as opposed to a situation where they're already there.
Now coming to laser, I think I was introduced in hands-on laser way back in 1990, 91 for coronary problems. So is it the same laser that you use for coronary as well as lead extraction, or is it different?
Sir, it is the same laser. It is the same console which is used for both the purposes. Like at us, we have the console which is most of the time with us, but our intervention cardiology colleagues, they use the same console, but of course a different laser. There's ELCA catheter for that, and they use that catheter for this purpose.
So what's the incidence of RV puncture? Because in coronaries those days, it was not so well controlled. The puncture was reasonably common. So how precise is this one?
Sir, once again,
what's the depth of the ray, laser?
Sir, it is, so the depth is in micrometers. It is very minimal. I don't have the exact figure, but what I can tell you is this, that if you are not properly trained, it is a very dangerous tool. There is high risk of perforation, and a simple movement like pushing the catheter, orienting the catheter in the wrong direction, has high risk of causing perforation. And that is the reason, while performing this procedure, we need to do it in the hybrid lab. One needs to be properly trained, and these are the maneuvers with which the overall complication rate can be reduced. For example, if I quote my experience, we have extracted 80, and out of those, we experienced perforation in 2 of them. So perforation, yes, it can occur, but we can significantly reduce its incidence if one is appropriately trained and careful.
So do you actually burn it out circumferentially, or you just burn it out in one side?
Sir, circumferentially.
Circumferentially.
The catheter is oriented in an oblique fashion, in which the longer end is directed more towards the inner side and shorter outside, but it works circumferentially. So the idea is just to point the laser catheter in the direction of the movement that we want to move. There's no need to keep it in contact with the tissue. It is slightly away from the tissue, it gives a pulse, and then we stop, try the outer sheath, and try to manipulate without using the laser. And if it is still not amenable to simple sheath, that is when we orient it again and give another laser pulse.
Doctor, you I just want to make a comment, Dr. Amer. It's really a wonderful case, and you presented it very nice way. Actually, as it is a fellow corner, just want to highlight one thing. First, it was placed in 2014, and secondly in 2022. What happened that it get infected? Because most of the time we are not looking after our checklist for infection control. So the take-home message is we must go and do that checklist properly so that we prevent all these complications later on. Thank you, Chair.
On top of that, I think right-sided endocarditis is usually related to drug addiction.
Exactly, sir.
I don't know what about
Thank you very much, Dr. Amer. Nice presentation, nice comments, and thank you very much, Dr. Mansoor, Dr. Amer.